Hello there. To whoever may be watching this, as a quick introduction, my name is Andrew Vande Berg, and I'm currently a student physical therapist at Campbell University, as well as a licensed and practicing athletic trainer here. And my topic that I'm presenting you today for my neuro project is, as listed above, sport-related concussions, a guide to clearance and additional considerations for physical therapists in North Carolina. So as with any presentation, I like to outline some goals. So our first goal here is to educate on the current state of concussion clearance in North Carolina and the required documents, to educate on increased injury risk for athletes following concussions, educate on VOMS testing and the research surrounding its reliability and effectiveness with and without exercise, and then to draw a link between using VOMS testing to identify athletes at a greater risk of injury following sport-related concussion. So what is sport-related concussion? SRCs, some statistics about them, is that they affect 1.6 to 3.8 million people per year under the age of 20. And some of the most common symptoms after this include headache, vestibular dysfunction, and sensitivity to light and noise. And so what we do know is, especially with regards to physical therapy, there is a CPG for aftercares following concussion. And initial aftercare is very clear and well researched. And we do have return to play protocols. But I think my piece and question that I wondered, just as a practicing athletic trainer and as someone who's worked in a physical therapy clinic before, is I was wondering if there is a missing piece related to sport-related concussion aftercare, and are we missing something? And the reason why I think this is all pertinent is because as of July 2nd of this year, 2025, physical therapists actually got added to the list of providers who are able to provide clearance for athletes to return to sport following concussion. And as an athletic trainer, I was previously already on the list of providers who are allowed to clear athletes for return to sport following concussion. And having worked at a physical therapy clinic and been able to do evals and treating with patients regarding concussion diagnosis, care, and returning to clearance, I just thought that this was a great chance to not only educate some of my peers who have asked me several things about that, whether I was working in a physical therapy clinic or my peers now in school who have questions about concussion and just what to do regarding the aftercare. And so, some specific considerations for North Carolina in particular. There is a law called the Geffeler-Waller Concussion Awareness Act. It was put into place in 2011, and its goal is to educate student athletes, parents, and coaches on concussion symptoms. And this also establishes frameworks for return to play after concussions here. And that's the main thing, is that every athlete in North Carolina who sustains a sport-related concussion must go through a return to play of some sort and be cleared by a medical provider before they can return to play if they've been diagnosed with a concussion. And so this is the current state of concussion return to play. In schools, oftentimes is where I'm going to be talking about, because sport-related concussions, sports often happen in conjunction with the school. So I will be talking mostly about that there in a school setting. But baseline testing of some form is highly encouraged. And this depends on what setting you're in, whether the school has an athletic trainer or a trained healthcare professional to help them with this. But any sort of baseline testing can include the SCAT-6, which is the Sport Concussion Assessment Tool, impact testing, which is a sort of pre-activity concussion testing to establish a baseline. And then concussion vital signs is very similar to impact testing, but is often free and is used by some schools in more rural areas. And then regardless of any sort of baseline testing, which is highly encouraged but not necessary, any athlete that does sustain a concussion, like I was saying earlier, does a 5-day graded return to play based off reported symptom management. And the average length of that return to play can go anywhere from 9 to 18 days. Technically, there's only 5 full days required to be performed, so you could come back theoretically in as quick as 5 days, depending on your symptoms. But oftentimes, the average length of return to play is 9 to 18 days, as said there. And like I mentioned before, there is actually a CPG for concussion aftercare for physical therapists. But with all this in mind, one of my questions that I had, that I thought about after hearing that this law was come to pass and that physical therapists can clear athletes for return to play, is what changes now that physical therapists are allowed to provide clearance for concussion return to play? Are there any skill sets in particular that physical therapists can bring to the table? That may be an athletic trainer or a physician who has already been clear, like who's been allowed, any sort of the previous clearing providers don't have necessarily the same expertise that we have. And so I have a couple of initial thoughts. One is that compared to other healthcare professionals, PTs have advanced diagnostic knowledge and rehabilitation techniques, particularly with regards to vestibular-based rehabilitation. And vestibular dysfunction was one of the main symptoms that we talked about earlier. Two, another thought that I have, having worked in this industry, is that clearance revolves around self-reported symptom scoring or subjective reports. And unfortunately, with athletes, competition and performance environment can lead an athlete to maybe try to misreport some of their symptom scores. And even though we know that this is dangerous, unfortunately, if a lot of our clearance relies only on subjective testing, this is just the way it is currently. And I think this can also be confounding because even if an athlete isn't intentionally misreporting their scores, most of these athletes that sustain sport-related concussions are below the age of 20, and their body is still developing. So they may not be aware of how their symptoms can present in their body, and they may not be aware what these symptoms are because they may never have even experienced them before in the first place. And so that's another barrier, an obstacle that I found earlier as I've worked with athletes returning from concussions before. And lastly, we as PTs have done the research and are aware of the increased injury risk rate following a concussion. What if more can be examined than just symptom management or just subjective symptom reporting in order to complete a return to play from concussion? And what if we can prevent a future non-concussive injury as part of their concussion return to play? And now you may be wondering why I make that jump here. And we're going to talk about some of the research about non-concussive injuries following a concussion here and why I think more physical therapists should have this on their mind. Now that, and not even just physical therapists, but athletic trainers and physicians in general should have this on their mind because this is pretty interesting research. And my thought is, especially as a physical therapist, if we can do anything that can help this athlete prevent a future injury, we should, and it would be our due diligence to help our athlete do so. So, what the research shows regarding musculoskeletal injuries, I'll call them musculoskeletal injuries to simplify it, following sport-related concussions, is that athletes who sustained a sport-related concussion were 2.11 times more likely to sustain an MSK injury within 2 years of their injury compared to a control group. Now, that's pretty massive because we just said earlier that the average return to play for a sport-related concussion is 9 to 18 days. And 2 years is a lot more days than that. So I think it's interesting that even though we can be very quick to return somebody from a concussion, they're still at an increased risk of sport-related injury within 2 years compared to a non-concussed group. And what the data showed from this first article that I pulled this research from is that both males and females were at a fairly equal risk of MSK injury following sport-related concussion, so there was no differences between genders. What I did find interesting is this was a meta-analysis, and it pooled lots of different articles. And in some of these articles, they used different types of control groups, which I thought was interesting. The obvious comparison is between concussed and non-concussed people, and several of the articles in the analysis did this. But then some of the articles included control groups of both non-injured athletes and athletes recovering from lower extremity injuries. And one of the biggest things that was found is particularly if we know that a sport-related concussion can cause vestibular dysfunction, is that non-contact lower extremity injuries were the most common injuries that occurred after sport-related concussion, such as a lateral ankle sprain or an ACL rupture. And this occurred in almost every single sport studied, except for with a few exceptions. There was no American football studied in this, but several of the studies included contact sports such as ice hockey and Australian rules football. And those sports actually did not see a significant increase of injury risk, mostly because the injuries that occur to the lower extremity in those sports often involve contact. And so I think, the main difference between non-contact sports and contact sports in general here is that the contact would cause the injury before a non-contact injury would occur with most of those subjects in the contact sports. So that's probably why we didn't see a significant increase in injury risk of non-contact lower extremity injuries. But I found this research pretty concerning because the fact that an athlete is 2 times more likely to sustain a lower extremity injury or any sort of MSK injury within 2 years of a control group following concussion. Athletes can sustain multiple concussions over the course of 2 years. And again, we haven't studied how much multiple concussions can increase the injury risk, but we already know that one can increase that within 2 years. So Again, what can we infer from the research is that the most common injuries appear to be non-contact in nature, and these injuries within themselves are highly predictive of future injuries. One of the biggest predictors of a lateral ankle sprain is previous history of lateral ankle sprain. One of the biggest predictors of a torn ACL is a previous history of a torn ACL. So again, we know that this seems like a dilemma here. A sport-related concussion can lead to further injuries, which can lead to even more injuries in the future. And so not only does a concussion rob this athlete of time playing on the field, but then also future injuries may rob this athlete of time playing on the field. So I had another question. Is there a better way that we can screen an athlete for risk of these non-contact lower extremity injuries? And there is a tool that I learned about in college and still use frequently with concussion evaluation. And I ended up liking it when I learned about it because it provided me more objective information to make my decision rather than just subjective information. But also now there's lots of good current research on the tool that I use. And the tool that I prefer to use is called the VOMS testing, the Vestibular Ocular Motor Screening Testing. And so it has 5 specific tests, or 5 different tests, and each test has a specific means of testing for vestibular dysfunction. And this testing is highly standardized. There are exact procedures and ways to do it, so that way you can have reliable measures and interpretations of results of these objective measures. Now, there is some subjective portion to the VOMS testing where an athlete can self-report 4 symptoms, such as headache, dizziness, nausea, and fogginess are the 4 symptoms that VOMS cares about. But the subjective portion of the VOMS testing is like the icing on top of the cake. Really what the providers need to get good at is the objective portion and actually performing the tests. And so this is also a highly effective tool for diagnosing sport-related concussion, mostly because the way the tests are set up is that each test as you go down the list should be more symptom-provoking than the previous test. And based off the research too, VOMS has incredibly high internal consistently. I think it was 0.99 and the highest you can get is 100. And it has moderate to good test-retest reliability between providers. So not only if you get good at the VOMS test, you're going to have a significant increased likelihood of seeing vestibular dysfunction between these tests, but even from provider to provider, there is still moderate to good test-retest reliability. So between other physical therapists or athletic trainers, we should all be seeing relatively the same things here. So based off this, I have a hypothesis. We know that non-contact injuries are more common following sport-related concussion. We also know that non-contact injuries can be related to vestibular dysfunction following a sport-related concussion. And additionally, we have an effective and simple way of identifying these deficits through VOMS testing. So my hypothesis was, can we use VOMS testing to identify and select areas where athletes may still be deficient in their vestibular dysfunction and incorporate this into their existing return to play to help decrease their risk of future injuries, especially non-contact lower extremity injuries. So as before, the VOMS has 5 unique tests here. The smooth pursuits, the saccades, which you do horizontally and vertically, the near point convergence, the vestibular ocular reflex, which involves the head moving, eyes focused on a stationary target, and the visual motion sensitivity test, which involves the head stationary and hand stationary on a stationary target with the whole body moving on top of it in a busy background. And so, as you go down the ladder from smooth pursuits all the way to the VMST, the visual motion sensitivity test, each of these tests are more demanding on the vestibular system. And so as a result, when you're performing this as a baseline or to check for injury, if any athlete has significant symptoms following one, you don't have to go all the way down to the end to make your assessment or your diagnosis. Now, when we're using this in the physical therapy clinic, I would like to see the results of all of these, no matter how symptom-provoking they may end up being, because we can use this to figure out which specific areas of vestibular dysfunction are most affecting the athlete. So, why did I select VOMS, and how does it relate? Is that we know, based off the research that you can find, that 80% of athletes with sport-related concussion show some sort of signs of vestibular dysfunction. Now, I have always done this when the athlete is relatively at rest, potentially in a clinic as well. But one thing that I realized when I was doing the research is, do we miss potential dysfunction because we are only testing these athletes at rest? Which led me to my next question, was does exercise affect the outcomes of VOMS testing? So interestingly enough, I found another research article regarding exercise and VOMS testing. And the way the article was set up was that they took both concussed and non-concussed athletes. They performed a VOMS test initially on these athletes. Then they took them through a sport, like an exercise. They've called it an SEC, but essentially it involved 20 minutes of cardio on a stationary bike, and then several portions of anaerobic exercise, throwing a medicine ball through various patterns and movements. And they found some very interesting results. Excuse me. What they did find was that for both sets of athletes in the control group and the concussed athlete group, is that all 5 testing criteria from VOMS showed increases in scores and symptoms following exercise. And importantly, regarding these scores, is there is only a 27.4 false negative in the score reporting when comparing pre-exercise scores to post-exercise scores. And interestingly enough, there were no false positives reported in these scores. And that is actually a huge piece of data when you think about it, when we interpret the data. What a false positive means that if someone were to have an increase in scores, but they were to not have the condition or not have some sort of vestibular dysfunction, as we're related to here. We can't necessarily talk about the concussion when we're talking about this thing here, especially when we're talking about the control groups, because the false positives are going to relate to the control groups mainly. But essentially what it means by having no false positives reported is that every individual who had vestibular dysfunction was captured by this exercise test. So anybody that was to have a symptom increase with VOMS testing following exercise was captured and reported appropriately here to have some sort of vestibular dysfunction. The false negative means that some people that did experience an increase in function sometimes didn't have necessarily the condition or don't necessarily have vestibular dysfunction. But another important piece of data to interpret here is that there was a larger total increase in scores of VOMS with athletes with sports-related concussions compared to their non-concussed counterparts. And so this is quite interesting, because even some of the concussed athletes before exercising in this group had pretty limited symptoms and were close to baseline compared to where they started, if they had baseline VOMS testing. And you know, they didn't have that many symptoms. So you would think that, you know, if they were in their return to play, they'd be fairly close to being cleared, or, you know, they were late stage, or they would be considered non-symptomatic by many. But, you know, once you go take them under exercise, which again, we're about to clear them to return back to their sport and playing, we saw a large increase in scores, particularly with the concussed groups. So I think that's just an important consideration to doing VOMS testing, because we can do a lot of things to clear a person to return to sport, but I think it would be in our best interest, especially if we were to utilize VOMS testing, to do it after exercise to get a better idea of, one, what particular dysfunctions that our groups may have, and then two, who is going to be at greater risk. Because if their scores are relatively the same and they don't show a significant increase, I think that'd be much more indicative of an athlete being closer to return to play versus an athlete who may have low subjective score reporting and their VOMS looks good at rest, but then we see significant increases during exercise. That person may be slightly further away from returning to play because of their significant increased risk of injury. So, in summary, this is kind of to summarize all the key points that we've talked about here. We know the current research. We know that athletes who experience sport-related concussion have a higher risk of MSK injuries following an appropriate return to play from their sport-related concussion. We know that most athletes following a sport-related concussion experience some form of vestibular dysfunction. We also know that these symptoms related to vestibular dysfunction can predispose an athlete in particular to non-contact MSK-related injuries. And we know that VOMS can be used as a baseline test, and with use under exercise can help to identify potential areas of concern for an athlete. So, my recommendations based off of all of the research and things that I've read before. So, initially, you need to perform all considerations from the concussion aftercare CPG for physical therapy. I think that's the first and foremost, especially if you see an athlete in the very beginning stages of after their sport-related concussion injury and they're not close to returning to play yet. That is the best place for physical therapists to go to understand where to start with an athlete. And then shortly after, what I would also do is perform VOMS testing both during exercise and at rest. After exercise and during rest. And again, if you're earlier versus later, you can scale the intensity of the exercise based off of what the athlete can tolerate. And then also some of the research said to develop an exercise plan to address any of the deficits following VOMS testing. So if the athlete experienced particular symptoms during 2 to 3 parts of the VOMS test, 2 to 3 specific testings, and then if you as the clinician can see some of the positive signs, whether it be, in smooth pursuits, say there was nystagmus at end range and say they had a hard time following your hand smoothly, you can develop an exercise plan to help with that, specifically to help decrease the symptoms and to help improve overall function with those. And if you have any questions on where to go, I will be developing a short YouTube series that kind of highlights these here, and that will be part of my project proposal. So that's all my recommendations here. Again, it's perform all the initial considerations from the Concussion Aftercare CPG for physical therapists. VOMS testing is going to be critically important to help you identify athletes that are at a greater risk of injury. And once you identify those athletes who are at a greater risk of injury, you can develop specific exercise plans to improve the deficits that you found during the VOMS testing. So, excuse me. I just wanted to thank you guys all for sitting through this presentation. I know that the material can be a little bit dense, and I was drawing some conclusions there and kind of taking you from one to another, so I hope I did that in a smooth manner. And then for all you that are wondering, here are my references, the 3 studies I was referencing most. One was about, again, musculoskeletal injury risk after sport-related concussion. The next was test-retest reliability of the VOMS screening tool. And then the final one was the exercise increase was the exercise increase the VOMS detection after a sport-related concussion. So those are all those there. And lastly, here's the list of resources that I think would be most pertinent for physical therapists to know if you're going to be working with athletes following sport-related concussion. Is the bill that allows us to evaluate after concussions, the CPG for concussion aftercare that I've mentioned several times, the Gefeller-Waller clearance form and act, and then a VOMS testing PDF. You can find VOMS testing PDF from anywhere. I just found this one through Impact Testing. But once again, I just want to thank you for listening. And then if you have any questions, please feel free to reach out to me in any way possible. Thank you very much, and I hope you have a great rest of your day.